invite Dr. Simon Thomas to talk on robotic related complex cases with an image-free burr-based system.
While I set up, good afternoon everybody, and thank you Dr. Prasad for actually inviting me over here. And as usual, it is very difficult to present after Dr. Rajkumar. His energy levels and the slides are unmatched. And it's trouble all the time, every meeting I'm after him. So I'll be talking about some cases in which the robot actually has helped. And, okay. So I think the predominant, the listeners are people who are actually not using a robot as of now. That's what my understanding is. Can I have a raise of hand of the people who are using robots here? Or have an access to robot, or you're seeing a robot every day? Okay, so I get, so I think for any surgery to be nice, three things have to be very actually important. First is a good planning. A perfect planning will actually half the things are done. The second thing is that what you plan, you do execute. A lot of us plan, but we are not able to execute on the table. And third thing is actually, which was never there for orthopedics. We do a great planning, we do great execution, but what we verify is actually when the patient has gone back to the room. So we think the tibia is invarus, some is a problem. You can't do that. And the struggle has to be to get all these things in order. And this is where technology chips in. We've been thinking out this for a long time. We had patient-specific instrumentations. It helped definitely in planning, but it had no help in execution, and definitely it would not verify. The navigation chipped in. It definitely helped in planning, did not help in execution, but it had this thing advantage that it could verify on table that what you have planned, have you executed that or not? And this is where the robot comes in, which plans, executes, and verifies. So the advantage of robot, you're all help, accurate cut, perfect mechanical access, zero error. And if you think this is the perfect plan of a robot, you're mistaken. This is just marketing. TKR was always a soft tissue surgery. It will be a soft tissue surgery. And I think all the previous speakers have actually gone on to that. We're looking at a functional alignment. If you want to do a functional alignment, then I think Dr. Rajkumar said that. If you want to go mechanical alignment, then you can do it by robot or a known robot. But if you are going for a functional alignment, then you have to have technology in chips in. I think this is one of the slides. You should go through the CPAC classification. In a conventional knees, we are actually trying to put the knee joint line perpendicular to mechanical axis. But in reality, the medial condyle is lower down, and the joint line is usual native joint line is not perpendicular to mechanical axis usually. So that may be one of the factors which can actually lead to I use the word may because this is all speculation. This may be one reason why patients are not happy. So this is a lady I'm going to present. The right knee is going to operate. 64-year-old lady, and I think I've unfortunately I've not got through the how we plan and things like that. I'll get to the slides where actually this is the default size given to me by the robo. And this is just about the both. The four neutral is narrow is the femur size, and tibia is 3, and size 9 is what we're aiming for. We had a preoperative alignment of 17, and we want a 0 degree alignment. That is the default which is given to me by the computer itself. At this point in time, I have the option of going ahead with a mechanical alignment, and or going a functional alignment. Now I'll tell you how we do a functional alignment. After the computer has given the bony cuts, now we do something called a stress test. I think all the previous speakers have gone through the slides. In this, we're actually stressing out the medial side and lateral side, and this is how the graph looks like. So the horizontal line here, I don't have a pointer. There's a one horizontal line between the gap and the overlap. We want, and the violet bars are all the lateral side, and the orange bars are all the medial side. So what is below the bar is all tight, and what is above this bar is all loose. So we know this is a varus knee, which is actually very tight in extension, and the tightness goes down as we flex the knee to 120 because the bar closes towards the neutral side. And the idea at the end of the surgery is that these bars should be as close to the midline as possible. And the default plan as is visible is here with the soft tissue now. The extension space is loose in flexion and extension and is tight in flexion extension again. So just for the sake of it, just for you to understand, see, listen, you should see this slide now where the femur size is for narrow. I've just arbitrarily taken a femur size to 3. What happens if we downsize? When we downsize, what happens? The flexure space should actually open up. And this is what has happened. The flexion space has increased, so it has become more lax. So we'll listen to the computer. We'll go back to the default planning of 4 narrow. And the tibia size I've made 2 because the 3 was a little overhanging on table. So I've again given an external rotation of 3 degrees. Now the computer shows me, I don't have the pointer here. Can you see that the top side, you can see the notch marking out there. The computer is telling me that with this kind of rotation, you actually will have a notching. So in order to prevent that, I've taken the component to flexion. So I'll go back the slide. The initial flexion was 3 degrees, but now I increase the component flexion to 4 degrees. My notch sign has gone again. And the tibial cut was distalized so that my extension spaces open up. And in order to balance more of the flexion space, I've increased the external rotation to 5 degrees. And my flexion space is actually more closer to the neutral level. Again, the notch sign has appeared. That means the computer is warning me that if you go through this, you'll notch. We have not taken a single cut, but everything is done on the computer itself. So in order to prevent that, I've anteriorized the femur, and this is how it looks like. Again, if you see the balancing in the flexions, you all can make out these 2 boxes, the extension and the flexion. In flexion, the bars are actually very close to the horizontal, but in extension, the lateral side is still very lax and the medial side is still very tight. So now I gave 2 degrees of varus to the tibia. That actually has relaxed the medial side. So it is now starting to get balanced. And this is one of the advantages that you can, again, so see, if you see the cross section out here, unfortunately I don't have the pointer here, you feel as though the anterior compartment, the anterior flange of the femur may notch the femur, but actually when you keep on moving around, you see that this is actually not notching. And I gave 2 degrees of varus again to the femur. Now my medial side is much more balanced in the extension also. But this was one of my initial cases when I was also not very sure how much varus to take. And by convention, I was taught that you stick as close to 0 as possible. So femur, 2 degrees of varus, tibia 2 degrees of varus, the overall alignment, can you see here, the bottom half here, the post-op alignment goes to 4, I was not comfortable. I came back to 1 degree of varus in femur, and this is the exception. One thing which I want to tell you, when you'll start using a robo, you may not be able to balance this to neutral all the time. You will still have to do some amount of release in some cases, especially in your severe varices. So don't waste your time and effort in actually trying to balance out to normal in all cases. So this was the final plan. I'll quickly go through that, and this is how it looks like. There was one time in which I used to verify all my points. Now I don't waste time on that because once you plan, the robot does not go wrong. And the bars which were actually hayway, the lateral were all loose and the medials were all tight. Now everything is a little relaxed. Everything is above, nothing is on the tighter side. So I know that these bars are actually relaxed and there is a balance between both sides. There's still a little bit of laxity on the lateral side, but it is less than the 2 mark, so I'll accept it. That is a convention. And this is what I get now. Somebody asked me, does a robo make you a better surgeon? How will we become a better surgeon? When we get data from what we're doing. See, this is what I ran. I had a 17 degrees of varus. We planned 3 degrees. We still have achieved a 5 degrees with a computer. So we are saying that computer is very accurate, but still my achieved alignment is 5 degrees of varus. So in spite of my correct cuts, my cementing methods, maybe I sometimes were using a saw to finish off those cuts, I still have an error, which was very, very, conveniently missed or ignored, but now the data is right on table. So the robo will not make you a better surgeon, but robo will give you data. And if you work on this data, you over a period of time will become better. This is how the X-ray looks like. Looks funny. In a conventional done knee, it may look funny, but I know there's a planned way in which I have put varices onto the femur, tibia, and I know they should do well. Another case, 47-year-old lady, rheumatoid, flexed flexion deformity on the left side. We are operating the left side. Sometimes in these rheumatoids, there's a flexion deformity. It's very difficult to analyze whether it's a varus or a valgus, because both sides it looks. See, you can have a long leg view, you can have a clinical assessment, wonderful. But seeing the X-ray, sometimes it's very difficult to realize whether it's varus or valgus. This is a lateral view it looks like. I'll flick through this. This is how the slide looks like. Now the medial side is actually tighter and the lateral side is relaxed throughout. So whatever it looks like on the preoperative X-ray, this is a varus knee. I'll go ahead with it. So whatever doubts I had, how to balance this knee has been countered by the computer itself. I will not go through into this. What you should now realize is that what the flexion range is showing here, it is showing -12. So this patient clinically, preoperatively had a flexion deformity, but once the anesthesia was given, she had a hyperextension deformity, which was obvious on table, and this computer detected it. So I will be actually now more careful. So this -12 was a little worrisome for me. I actually went back to the planning stage. I did all the collection again because I was not very sure, but it stuck on to -12. And I think I'll skip through all that. The external rotation 5 degrees, and this is how it looks like. And this tibia, I have proximalized because the other side, the spacer went very high in spite of my mind. So actually I proximalized, and this looks very tight in extension, but I was able to get away with a 9, insert in this, and this is how it looks like. Post-operative, this is the X-ray looks like. Again, I've got a lot of data which we analyze at the end of the day. And I have still got a little lateral laxity, which is more than 1 in flexion. So again, one thing which I'll also harp about is that, see, when we were all, 15 years back, when I started doing my knees with my boss, when I had to give a knee a spacer, I would put, say, a 9 spacer. It would go easily. Then I would have this thinking, maybe this is a little too loose, and I'll give an 11 spacer also. If 11 and 9 went, I would actually choose 11 spacer, mainly because we are all see, when it is left to us, we will actually want a tighter knee because we don't want an instability. But with a robo, you can actually assess stability better, and we can actually stick on to a knees which are lax. This is how the post-operative X-ray looks like. And this is my final slide before I end up. This is the ghost that we usually talk about. I think a lot of my colleagues who are here will understand this graph. This actually, 0 to 30 degrees, both look balanced. 90 and all, actually it is balanced. In between 30 and 90, there is mid-flexion instability. Why is there instability? Because both medial and lateral are lax. This is something which I have never seen on table. This patient I did robotic. I felt it was wonderful. I don't know how this patient would do, because when I was doing conventional, I never diagnosed this on table, and I brushed people who were coming to me, theek hai, ho jayega. But this patient I'll keep under watch, because I know that the computer has told me there is mid-flexion instability. To be very honest, I did not have an answer to this. I accepted this. I went on with the surgery. This patient is 2 weeks down the line. I'll tell you some story at some other conference. But when the answer to what Dr. Rakesh Rajput asked, is the robot making you a better surgeon? No. But it's giving you more data. And if you analyze that, one day you'll become better. Take-home message, robot is not about taking the perfect cut. Robot provides much more objectivity to soft tissue tension that was ever available to you before. Surgeon experience is definitely vital. You cannot become a good surgeon if you don't have the basics of knee replacement with you. Intraoperative verification is at all-time high. And data generated through robots is immense, and this is what is going to make you and me a much better surgeon over a period of time. Thank you so much for your patient hearing.
May I request Dr. Sanjay Srivastava to ask any questions to the faculty or delegates?
It was... I was just thinking about that, because majority of the people sitting here, they are not into robotic, they don't have an exposure of the robotic. They are stormed with the information related to our... And all the surgeons who are doing it, they are so passionate about it, you want to convey everything to the people. One thing I would like to ask one by one with all the faculty that all of us has been doing thousands and thousands of knee before we entered into this field of robotic. What change it has made in the life of your patient? We are happy as a surgeon. We are very happy. Once we come out of the theater, we feel that we have executed the thing in a perfect way. But how it has changed and how it should be conveyed to the delegate?
For that, we need to wait, first point. So, as I told, early assessment, the results are promising. It is good. It is definitely a very good tool in regards to assisting in precision, definitely. But to transform it to the patients, the first patient wants is longevity. Even sometimes patient is ready to compromise little bit of functional problem, but they want longevity. So regarding longevity, we have to wait and see. We need a lot of studies, randomized trials. We need level 1 studies to say, yes, robot will definitely give longevity. So for that, we need to wait. Early results, definitely promising. Whatever system that is different, whatever technique different, whatever alignment, surgeon individualized, but results are promising.
The same question? So I would say first difference to me and then the patients. Number one, every patient gets a report. There is a full report of data. Previously, it's so easy for me to say, Dr. Arora's case comes to me, oh, there could be flexion instability, there is some problem. And now when data is there, the surgeon looking at it knows that it is a perfectly balanced knee. So he should think about other causes of knee pain because all robotic patients are not going to be happy. So I feel when the other surgeon is looking at your case, at least he can say that the technical part is good. So we have to think of other parts if patient is unhappy. I have more confidence that I am reproducible all the time. So I have a reproducibility. I know what is going to go inside, how I have balanced, which was lacking in all the mechanically aligned knees like flexion instability. Then early results, definitely promising. Late results, data says no. Recent paper, it said no. But I think still, these systems, I think it does vary from geography to geography, and I believe that we need to have more collection, collaborate amongst each other, Vallis, QVIS, everything, so that we can find out if it is making a long-term benefit. Longevity of implant, it should. Why not? If I am placed perfectly, why my implant will last less time than the mechanically aligned knees without robot? Why? So logistically, it should make my patients happier and a longer life for the implant and lesser soft tissue inflammation, so faster recovery. That's what I feel.
So I agree with them. I don't think the robot will give us better results on studies because it's the same surgeon who has done the surgery manually. If he's a good surgeon, he'll be a good surgeon manually and robotic. It's for the surgeon to get this knowledge from the robot and to implement it in further cases. But if you looking on how to change, maybe in the future when we have the large volume of data, it will assist us. For now, we don't have data about like the ligament laxity in a normal people. And we say that it has to be like perfect in extension and in flexion. But we don't know how in normal people who are not arthritic, what's the situation. So this is also data that we lack to do it in a robotic way. So I think that you won't see results. Of course, the short-term results are better because we don't drill the femur, that's less pain, of course, and any other measures that we don't do much releases, that also less pain for the short time period. But for the long time period, it depends on the surgeon. If he did the surgery good in regular jigs, he will do it good with the robot.
I think I'll be running the panel, so I'll skip If it's okay, I'll be talking.
Yeah, and to add to it, see, earlier we were talking amongst ourselves. Yeah, flexion, do you keep flexion tight? Do you keep extension tight? How is the soft tissue feel? Now we can objectify. I remember getting a call from a very senior surgeon. Aurora, I have heard you keep your flexion a bit tight. How do your patients behave? Now I have an objective method where I can measure on robot and in follow-up and see how do they behave.
Anil sir, yeah, the question was about patient benefit rather than the surgeon benefit.
So again, it'll give me an experience over the years when I follow them up that if I keep soft tissue balancing like this with the objective evidence, how does my patient behave in follow-up? So it'll teach me also. So that will benefit my patient, number one. Number two, earlier we did not have an objectification for our juniors. That I'm feeling like this. Now we can show them. So they can pick up. You can bring up a legacy. You can bring up your own junior team who can carry on with whatever parameters you are doing. So objectification element is very high. And with small play around in femoral tibial component, you do less soft tissue release. So these benefits I see in robotics.
I'll just conclude this discussion with two small comments. There are now papers coming up with patient-reported outcome measures, the SF32 and all those scores. And definitely there is an early benefit and early rehabilitation as far as robotics is concerned. And number two is that in my practice, I think the indications for partial replacements, they have increased. There are some systems which are giving partial knees, and these people are extremely happy people. With conventional partial knee, there were a lot of outliers and a lot of early failures, but we have also published a paper with 600 patients with minimum 5 years follow-up, and there is no failure of the implant or revision due to instability or any surgical related problems. I'm not counting infection. So definitely in that aspect, or even patellofemoral arthroplasty, I think technology has got definitely some great...
around them is also good. May not be very true for very old patients, but the newer generation is little more convinced, which I feel, maybe in a psychological level.
So it's clear that the man behind machine is much more important, the first thing, and the possession of an instrument is not a license to do it. These are the two basic things.
Rather, it is difficult to, there is a learning curve. If you try
Yes.
to change from conventional to this, there is definitely...
That's what I want to ask. How many surgeries a young knee surgeon should do before pouncing on robotics? That's the one question I want to ask. Anybody can answer from the panel. Because directly pouncing on robotics makes no sense.
I think monthly 10 to 15 TKRs he should be doing.
But first he should have a basic knowledge how to do a TKR without robotics.
Absolutely right.
Only he can refine it. I think that's the message we should give. Because every time a new gadget, old is good, new is good, but old is not bad. We should not forget the basic principles of total knee replacement.
Sir, very debatable, sir. Very debatable. People who did knee replacement the first time, they never had any experience of knee replacement at all. They started it. Now that we were taught that you should do this much and only you can do, I think that is a little overkill. And I think...
No, it's not. Because when you come to robotics, the whole knowledge has to be there so that you can plan. That you have to do in plan. So it's more important than a conventional surgery.
So I think we'll finish up this session because the next session is again on knee symposium and we have got luminaries on joint replacement who will be speaking there. But yes, I agree with Simon Thomas. There was always one time when you start doing robotic, the first time it is your first robotic experience. So whether you are doing 10 or 15, I do not know. But I can tell you, if you listen to all the talks, the robotics or the computers, whatever AI, this will give you so much of information per operative and you know what you're doing. Every step can be verifiable. So this is a good thing. So what I might take is robotics or the AI will give a good surgeon produce excellent outcome. So first you have to become a good surgeon and then you try all these things. Thank you.
Sir, ये करना है कि छोड़ दूं?
Now it's your baby.
No, not mine. If people want, I think you have had enough of robot.
I think panel discussion will be among yourself only, not from the delegates.
Okay, so we'll just ask few questions. So one was, one question, can I have the other guys still here? Please. So Rajkumar, we had a discussion about varus, how much to put on tibia, how much to put on thing, and the kinematic one would go unlimited, but then came the restricted kinematic, putting some restriction to it. And so I want to ask you, would you divide this restriction between tibia and femur, or would you go all out on one of the
one request, Dr. Rajput. I think the delegates will not prefer to have a discussion on the nitty-gritty of robotics. How you do registration, how you do, because they are more interested on the outcome. I'm sorry, this from the feedback. And what is the difference? How you feel different? So that's what we ask.
According to you, based on that question, quickly, in regards to young surgeons, a severe varus knee, they should not aim for neutral or a valgus. They should not think, okay, let me put the knee in 1 degree of valgus. A severe varus, it is not good to take it to valgus. Better to keep it either neutral, or in fact it is preferable 1 or 2 degrees of residual varus. That should be the thing. If non-robotic, not to put the tray in 1 degree or 2 degrees of varus, definitely it has to be 90 degrees mechanical, perpendicular to your mechanical axis. That should be the point.
Hemant, for you, for the audience, what you have learned in robotics, is that helping you in normal operations?
Yes, it does make me, when I do a normal knee, so I can figure out a lot of things like instabilities, as I said, keeping the knees in varus. So previously I was more into exactly 90 degrees. Now if there is some varus left, I'm quite happy. If my femur is in varus, I'm quite happy. I am focusing more on the joint obliquity and stuff rather than going into purely mechanical.
Good. Anil, for you, when we have 4 degree varus and when we are going for mechanical, we call it malalignment. And when we are doing robotic, we are calling it, I wanted to do this. So for our audience, can you just clarify this point?
Yeah, to some degree of varus is acceptable, and the femoral and tibial combined not more than 5 degrees. So that is totally acceptable, and now we have long-term studies available with us. But when you are doing mechanical, don't aim to put your tibia into varus purposefully, because you're not able to control that. With robotics, you're able to justify and see it is only 3, it's not 4, 5 or 6, whatever. So that has helped, undoubtedly it has helped.
Dr. Nabil, has your exposure changed since you've taken up on robotics? Anything different in your exposure?
Not that much, because I started doing the kinematic alignment before I started using the technology, before the navigation and before. So I stopped medial release many years ago. So the incision isn't different. Sometimes I elongate the incision more proximally because of I need to put the pins for the femur. I put them inside the incision, but otherwise it's the same.
Amit, for you, do you think since you've taken up your robots and doing normal operations, your medial release has become less?
Yes, definitely.
Okay. Let's ask the father of robotics in India now. Narendra, one small question, has your operation really, the approach been a bit different? And number 2, can you put that 2 degree varus which everybody is talking with robot on tibia with conventional instruments?
No, with conventional instrument it is unmeasured and you don't have really control over that. Some companies have got a jig which is actually at 2 degrees. Like Zimmer has got a jig which comes in 2 degrees of varus. So if you have specific instruments, you can try with that. But otherwise, it is uncontrolled with the conventional.
But how do you know that you need that 2 degree varus in conventional?
How do you?
How do you know that you need that 2 degree varus in conventional?
In conventional, basically, I think 2 degree varus, just native knee you have to measure and then you have to plan for it.
Okay. Simon, about the Wallis system, or you're the Corey man. So we know that the precision industry everywhere in the world requires burring. But most of the doctors here use saw. What do you feel about burr versus saw?
I love it, sir.
You love it. We all, when we come in, you know, in our open forum, we always say, I love my wife. But inside we know what actual truth is. Okay, I think, so I think
Dr.
for the
Rajput.
whole panelists, do you have a message from your side? Do you have a message for the delegates here? Should they pick up robot or not?
Not yet. I think there is time, but if you are very keen to use technology, you can. But still, I think long-term data has to come and the cost has to go down because the match has to be there for the wider use.
And Dr. Rajput.
Right. Yes.
Yes.
Like if they want, they can.
Regarding whatever discussion is going on, as a robot user,
You were supposed to be here, isn't it?
I was just sitting there. As a robot user, what I have learned, because I have made it more precise. When I was doing a conventional surgery, I used to accept, okay, it's fine. Now I know my boundaries, because that's one thing which has happened. Secondly, as Dr. Vaidya has said, that you can play with it. Previously, we knew that 3 degree of varus on tibia and 2 degree varus on femur can work, but we never dared to do that because we never knew at what time it will become a 5 degree or 4 degree on the femur side. So that's two things which has changed in my practice, and I think that's for good.
So you see, orthopedic surgeons never seem to grow up. They still want to play. Right? You see this graph here. Today we are debating robot. Mind you, my dear guys, all these things are going to hit you very soon. Augmented reality is already here. Virtual reality here. Combine them and you have metaverse already here. AI. There is slight difference between robot and AI. So AI is hitting us. Anybody know what blockchain? Anybody idea about blockchains? So you need to be a businessman to know blockchain. Whatever you do is like a data, you feed this data and you cannot alter that. It's linked to different chains. So only one server will have that control. So independent people can't. So now everything becomes a data. So every operation you are doing actually has been recorded and it's become a data. And you cannot change that. So it's called blockchain. So all these things are hitting us. Tomorrow you'll have 3D printing is already here in India. So 3 of these things we already have. 4th and 5th are already hitting us. So we are debating just the robot here. And look where the whole market's being going. You have to be more and more precise. Today, just doing a knee is not acceptable. We have to agree we have 20% bad results. Whether these things will help us in those 20% results is for time to say. But if we don't try, we'll never get there. Thank you.